My name is Kåre Norgard. The purpose of this video is to show you how you can get happier customers and at the same time document your quality. Happier customers or happier patients and their relatives is achieved through them being able to track their own treatment, to see the treatment as it evolves, get a full plan for what they have to go through, a plan that updates as they go, and understand all the decisions that have been made. And this is a big revolution of healthcare in that every time you get a diagnosis for something, you get a link which will take you through all the things you have to go through all the way through your disease until it is cured. And that means that the participation will be a much higher one, and you can understand your own treatment. And the quality will be documented in that you can document that at any time, and given the information you had at that point in time, the decisions you made were correct and in full conformance with the guidelines. And thereby, if anybody challenges that, you can prove the contrary. So what I will do in this video is I will show 3 testimonials from breast cancer survivors suggesting that they would have appreciated this tool that I'm about to present. Then I'll spend a lot of time on proving that we can now model the breast cancer treatment, in fact any treatment, as a rule-based workflow, and thereby, since it is a rule-based workflow, we can show it and enable patients and their loved ones to be involved. So I'll spend a lot of time on proving why it is now possible to do that. So far, it is thought that it has not been possible, or it isn't possible to do that. So that's why I'll spend a lot of time on that. But let's turn to the testimonials now, which are on YouTube, and you can Google them yourself. So I have found a file or a YouTube reference here that explains 3 cases. And let's listen to the first case.
Mayo Clinic. To me, that is very important because there are subjects or information that's shared during those conversations is very relevant to what I'm going through as a cancer patient. There are a lot of experts or doctors or care providers who come and speak or share their knowledge and experience is something that I'm looking firsthand. So instead of going and buying a book or trying to read online and not knowing if I'm getting the correct information, coming here once a month, being with others who are going through similar breast cancer or other cancer treatment like I am, being surrounded by them and sharing our experience, laughing, talking, along with a cup of coffee, and at the same time getting all the information that is pertinent to my treatment or something I may have missed, I may have not even known. All that information that they provide is vital, and I look forward every month coming and being part of this Coffee with Conversation.
All right. You may notice that what she said was that a lot of information got shared, and this was important to her, and that she would have looked it up online. Now, I don't think that we can prevent people from looking anything up online, but we can supplement and give that information so that when they Google something, they Google the right thing. And that way they can see what happens to them peacefully and at home, and that they would probably appreciate. But let's look at the second testimonial. So I'll just have to move the cursor here. Yes, that's where it is, and we'll go ahead.
And so I was scared because I didn't have answers. And once I got the answers from Mayo, then I was at peace with everything, what was fixing to happen to me. They gave me a plan of what they were planning on doing, and I was like, okay, let's do this. I also have, two other friends that also went through breast cancer at the same time I did, and we all had the same type of breast cancer. So I already had a support group, and we would just talk and ask each other how we're doing and what's going on with your treatments. And so I really do think that having other people, talking with other people who've experienced the same thing as you, just kind of makes you feel like, okay, I'm not alone.
All right, you might notice several things here. First, that she actually was scared until she got answers. And then she appreciated that she got a plan from Mayo Clinic, the hospital that treated her. So we deduced that that information, it might actually have been given to you, but you might not have noticed it. But getting that in writing will be something you appreciate very much. And getting a plan, of course, will elevate you a lot in terms of understanding your treatment, and then you will be at peace. The other thing that you might notice is her mentioning of a support group. Now, this is a place where we have to be a little careful, because sometimes you make the erroneous assumption that your cancer is similar to somebody else's cancer. So, for instance, if somebody else successfully has declined chemotherapy, then you think that that is something you can do as well. And it might be, the situation might be that your cancer is different and you shouldn't decline it, etc. So it's very important to get exact and precise information that's pertinent to your case. All right, let's now look at the third testimonial. And it is a man, because men can have breast cancer as well. It's called male breast cancer, and it's not at all rare. So 1% of all breast cancer cases are male breast cancers. So we should do more probably for men, but let's listen to him.
Healing will follow. The other thing that I would tell people is, and this is a big one, I tend to be very self-sufficient, but you really want to have a support person come to those appointments with you, because there were times my wife would say, oh, she said this, and I wouldn't have that in my notes just because there's so much. And so having a good support person to both be there for you, but also attend those appointments is really helpful.
All right, there are several things, but one thing that you might notice here is that involving support persons is crucial, of course, but also that something said might not be noticed by the person himself or herself, and it might be very important information that has been said but hasn't been noticed. So that's why it's very important to get something, or get all the important stuff in writing. So these are the three testimonials. Let's now turn to what we think they would have appreciated a lot if they had this at their disposal. So in Cure TBS, and this site is something you can try yourself, because everything I show is already online on this site called curetbs.org. But in Cure TBS, we have developed a breast cancer treatment. And I'll just start by showing you what it can do, and then I'll go into detail about how it is possible to do that. But the thing is that it maps out the treatment plan from first diagnosis to final cure. So you have the treatment plan to your left, and there are several things going on. Of course, the whole treatment is there, but at certain points in the process, you can extract the data record, for instance, which holds all the information you have supplied, all the decisions that either are made by the doctor or by yourself, etc. And you can say in this case, it's a woman that has periods still, etc., yes or no to a lot of things, and then we can go down in this and see that the cancer is ICS, it's ductal, there's no Paget's disease, etc. Then it's not inflammatory, it does not involve a muscle, the tumor diameter is smaller than the threshold for neoadjuvant, which is why you don't have neoadjuvant treatment in this case, etc., etc. Then there's the projected date for surgery, November 3rd, and a lot of other things. Later, if chemotherapy comes into question, you have to notice your body surface area, etc., etc. And there's a lot of data, and it's pulled fresh as it stands whenever you pull this report. Therefore, there's a timestamp at the bottom saying that this report was pulled October the 28th. And you might notice that you then get a lot of person-centric documentation that you wouldn't get anywhere else, because there's so many ways you can combine a breast cancer treatment that giving this text is not possible today, but it's now possible, so that you can actually see in pure English what the breast cancer treatment is all about. And pure English, by the way, if some of your family is Spanish speaking, you might pull up the Spanish language layer, and thereby they can actually see the whole flow as it evolves in Spanish, and you can see it in English or in another language. That's the report. But many things happen all the way through. One of the things that happens is that initially you have to set, of course, which country you're in. Now we can hard code that, but I'll just show that in cureGPS.org, since it's a global website, you have to select the country by which your guidelines must obey or be conformant. So for instance, I'm from Denmark, and if I chose Denmark, I would have a different set of guidelines. If I was in Israel, I would have the same guidelines as in the USA. So for this trial site, we have to select the country initially. And then there's a lot of other information, and one of which is the genetic risk assessment, which in this case is quite comprehensive. It's saying that you don't test positive for BRCA, but you have a mother who had breast cancer at the age of 42. And this would mean, if we expand the breast cancer risk, that since her age was 42 when she had breast cancer, you're not at risk. Then you can add another family member, but it's a lot faster to say that if she had breast cancer at the age of 37. You will notice that automatically it calculates that, hey, that's early, and therefore you are at risk yourself. And it will then conclude that that you have a strong family history since she's 37. But if we return to 42 and tap out of that field, it will find out that you don't have an elevated family risk. And that comes into question when you make the surgery decision. So since you don't have an elevated risk, you can consider having breast conserving surgery. Now there are several other factors into that decision, which is one of which is that if you had radiation in the past, you cannot have it again. And since you can't have it again, then you can't have lumpectomy or breast conserving surgery, because it would mean that you have to have radiation again, and you can't have it again. So therefore, if you had radiation before, it will recommend a mastectomy. You can still then choose a lumpectomy. And there are a lot of other factors. So the thing is that the tool handles all decisions and explains them to you. So going through the treatment, as a companion, you would have a link that continuously says what are the steps you have been through. They are checkmarked here as well. What are the future steps which are not yet checkmarked? So this is a situation where the next step probably is the surgery, and then it will hold your hand all the way through. So that's the kind of tool. And I'll now explain how we make it possible to share that treatment online between the hospital and the patient's network. So in order to do that, I will share a presentation. And what you see when you express the treatment for breast cancer is this. This is a breast cancer treatment. So the blue arrows are all the high-level activities that you might go through, from neoadjuvant treatment or medication, through surgery, through a lot of adjuvant steps that I've condensed into the blue arrows here. Then the green boxes will be used by the oncologist to determine which variant you have. And the problem is there are 300 independently determinable decision variables in the treatment that you have to set to yes or no. So just to give an example, I've picked less than 20 out of those 300 decision variables that you have to set. First of all, is it a man or a woman? Second, it's often a woman, 99% of the cases. Then the next decision variable is whether she is pre or post menopausal. The next decision variable is that if she's pre-menopausal, is she then pregnant? Yes or no? Is he or she young or old? Did he or she have radiation in the past? As I explained, it is important to know. Did he or she have, does she or he have an elevated family or genetic risk, as I just showed? Does she or he have drug allergies? What are the preferences? Is the cancer big or is it small? Is it a single tumor or multiple tumors? Is it invasive or not? Is it ductal or lobular, something specific to breast cancers to women? Is it grade 1, 2, or 3? Is it ER positive? That's estrogen receptor positive, or isn't it? Is it HER2 positive or negative? Are the lymph nodes hit, etc.? So these are 20 very important things to know, and the outcome of those variables, or the values, yes or no, of those variables will determine the treatment path, and they may change as you treat. So it's that which makes it very hard to imagine that a computer can help in configuring and devising the treatment. But CureGPS can do that now. It can hold unlimited variants because the nature of the software is such that it doesn't get or explode in complexity when the problem grows to a big one, which 300 decision variables is a big problem. It represents the solution as a project plan, so you can see when you go through what, and then the problem can change as you solve it. The thing that an oncologist has to handle to determine the breast cancer treatment on a very high and simplified level is this. So the same three phases to the left here, denoted as red arrows to the left. And the blue phases are here activities in numbers from 1 through 9. And you can see that the neoadjuvant activity, number 1, must be there if it's a large tumor. There are other considerations as well, but we'll just simplify it to say that a large tumor means that you must have medication first. The second and third steps have to wait for neoadjuvant treatments if it is there. So they have a predecessor of activity 1, and lumpectomy is relevant if you say no to the family risk, and mastectomy is relevant if you say yes to family risk, and if it is a large tumor, or if it's a large tumor. a little simplified. There are other things going into that decision. Then we set, and that is why we put an S here, and it is not red. When you have lumpectomy, we will find out whether your lymph nodes are involved, and you will have breast conserving surgery, S here under BCS. And if you have a mastectomy, we'll also find out if your lymph nodes are involved. And if your lymph nodes are involved, and you can say yes to that, then you must have lymph node surgery. And it must await either lumpectomy or mastectomy. Then we go on and configure the adjuvant treatment, the last phase here, which is actually a long phase, up to 10 years. So you must have tamoxifen activity number 5, and it must await chemotherapy number 7 if it is there. If it's not there, you can have it right away. And it is relevant in case you are premenopausal and ER positive or estrogen receptor positive. That means hormone receptor positive. Then you must have tamoxifen. And if you are not premenopausal and but still ER positive, then you must have aromatase inhibitor followed by bone loss treatment. So it's either of the two actually. But this whole state being premenopausal or postmenopausal might change during the 10-year treatment. You must have chemotherapy if it is a large tumor, and you can say yes to that, or you are premenopausal, in which case you must have it unless a recurrence score is not saying that you should have it. If it is a HER2 positive tumor, then you must have it as well. And you must also have trastuzumab, which is shown in line 8. If your lymph nodes are active, you must have it as well. And the way these decision variables play together is not a simple and or rule, so that's why I've written complex here. You can have chemotherapy right after the lymph node surgery, so that's why we only put 4 as a predecessor. If you have trastuzumab or Herceptin as part of your treatment, it's there for a year, and you can have it right away, except it says 7, or that's the chemotherapy step here as a predecessor, in that part of the chemotherapy might contain a so-called taxane, which you have to wait for to be given and completed before you can actually start your trastuzumab component. Finally, step number 9, radiotherapy has to await the chemotherapy to be completed, and it's relevant in case your lymph nodes are involved or you have a breast conserving surgery. So the whole thing is that this picture is in the heads of oncologists, and it's a picture that would have been nice to convey. You don't have to understand the picture itself, but you have to know where you are in this whole configuration, and your breast cancer might therefore differ from your neighbor's breast cancer or somebody in your network. What you see here is also a process matrix, in that instead of showing it as a flow chart of activities, we have done a matrix where we have listed the main activities to the left and supplemented with, in green, decision matrix that shows when a particular activity is relevant in your case. So in order to explain the process matrix, we have the opportunity to show a simple flow in flow chart and the process matrix that is similar to that flow. So this workflow is the same, described in 2 different formats, the flow chart on the top left and the process matrix bottom right. So you see a simple workflow that has 3 activities: paraclinic, surgery, and medical. You have a decision in the middle saying, is it serious? If yes, you have to have surgery. If no, you have to have medical. And the same is shown here at the bottom right. The same set of activities, the same decision, and the predecessors are 1 in each example, so that corresponds to the arrows you see here in the flow chart. The problem is that you can do that for quite up to a certain limit, and then the flowcharts will suddenly explode in complexity, and that happens long before you get to diagramming a cancer treatment. So this is again a flowchart at the top with forms and the same workflow depicted as a process matrix. So you can see that a process matrix follows the flowchart more or less in complexity. But the problem is that a cancer treatment has a very high complexity in the problem that you have to denote, and the solution is also very complex. And that is why a flowchart, which you have down here to the left, doesn't work in this area, because a cancer treatment has 300 independent decision variables, as I showed before, and they can each be yes or no. That means that if you compute the number of variants, it's to the power of 300, and that's a very, very high figure, which is way beyond what a flowchart can handle. Actually, it can handle only roughly 7 decision variables, and then it's immensely complex and impossible to implement. So you have to use the software in the treatment quadrant, or up here to the right, in order to convey the treatment of a cancer, and that's what we have implemented. So for a simple flowchart, you can actually have the same process matrix, and this is again an example of a flowchart and the same workflow as a process matrix. But once it gets complex, like a cancer treatment, the flowchart stops working. So the process matrix for the cancer treatment is like this. And all the activities are shown to the left, and there are 250 of them in any particular cancer, so there's more than 250 to choose between. The number of decisions are 300, and they determine which activities are relevant in your particular case. And then we have data elements, and decisions depend on data elements. So if you see the type of surgery recommended, you can see the rule behind a mastectomy recommendation is a little complex. It has a lot of inputs here that we can use the tool to compute, one of which is previous radiation, one of which is family risk or family history, etc. And there are a lot of other, or a few other decision variables that all make sure that you make the right recommendation. And the whole tool implements these things. So what the process matrix you just saw, if we translate to headlines, it handles these many items that you see on this diagram. And if we go through these items one by one, and we'll just take a few and start from the bottom, the top left, sorry, the bracket test, it will show the step that you just saw before, trying to, or giving as an output the genetic risk that you might have or don't have. In this case, the mother had breast cancer at the age of 38, so you have an elevated risk, and that's just one step in the overall workflow. Then it goes on and finds the tumor characteristics, something you might have from the mammogram, and then it goes on and configures the kind of decision like we just did. And then it computes whether you should have neoadjuvant, that means medication, before surgery. And there are a few other decisions to be made than whether the cancer tumor is big or not. And they are handled by the tool as well. Then it goes on and configures the adjuvant treatment, as we just saw before, whether you would have chemotherapy, radiation therapy, hormone therapy, etc. And the documentation of that is served straight in the tool to you, so you can actually read. By reading the text, you'll get a plain English or Spanish documentation saying what is your case and why have we recommended to do this or that. And part of it is the pathology report, so it will either come as data from the pathology department through the electronic health record, or you can ask your doctor to key it in. So it says that if you have 66% of the cells that respond positively to estrogen, then you are ER positive, because the threshold applied is 10%. So 66 is more than 10, and therefore it's ER positive. It's HER2 negative. It summarizes the conclusions down here. It says it's ER positive, HER2 negative, and it also finds out that it's grade 1. And since we have that particular combination, you should have a genomic test which determines if you have benefit from chemotherapy. The output from the genomic test is handled by the tool as well, and it says, as you can see on the bottom, if you apply in this case, the Oncotype DX test, it shows that you will benefit from chemotherapy, and therefore we offer it, and then we record whether you actually choose to have it. And we give a text that explains in plain English why we recommend this. Finally, radiotherapy. Whether it's offered or not, and we record whether the patient will choose it or not. And then it devises a project plan, and you can see that the surgery is planned for October the 31st. And since the chemotherapy then has to wait for 21 days, or that's 3 weeks, then the chemotherapy will start on November the 22nd and last for 126 days until March the 28th. March the 28th will then be the date on which you can start tamoxifen treatment, which is for 10 years. So far, we plan for 10 years. And radiation therapy will start on that date, March the 28th as well, and last for 35 days. And thereby you have the project plan. And on it goes, interleaving a project plan and collecting data and showing decisions and explaining them. And then it finally, or all the way through, in fact, it has a lot of data that it manages. And I'll just give you an impression of the wealth of the data set that it manages. Here is the personal data about periods, premenopausal or not, etc. Then there's radiation in the past, the selection of whether there's a Paget's disease and the mammographical conclusion. Then there's a characteristic of the cancer. Then there's the staging information, which and finally which surgery is recommended and which you have chosen. There's the configuration of the adjuvant treatment. Then there's the selection of chemotherapy combination, because it's typically 3 agents in combination, and there are several that you can choose between. And then it has other information about drugs. Then it computes the body surface area from your weight and height. Then it collects information about comorbidities, and it makes a conclusion about the tumor characteristic and monitors the heart, because that's important when you have chemotherapy. Then it collects the data from the pathology report. It collects and summarizes the data from the genomic tests. It computes the dose of the 3 agents you have in terms of chemotherapy. And the first one would be cyclophosphamide, which is a weight-dependent dose calculation, and it computes it correctly from your body weight. And the 2 other agents, fluorouracil and doxorubicin, are dependent on the body surface area, which the tool has computed, so it correctly computes the dose that you should have of those 2 agents as well. Then it goes on and computes the radiation dose as well. So thereby there won't be any errors in the decisions made. If your body weight changes, for instance, it will remind doctors to re-evaluate the dose. and the new dose will actually be evaluated and suggested by the tool. And if you go by the tool, you won't make any error. So the whole point is that by doing all this, we can enable the patient to participate in and understand the treatment as it evolves, probably with the help of relatives and other loved ones, because they have a cooler head and will appreciate all this information, but they will as well. But in addition, the person here, the doctors, can make decisions and document that they were right. And the reason they can do that is that every decision suggested by the tool has a formula behind it. Like you see here for recommendation of lumpectomy, which I've shown before as mastectomy, but they are mutually exclusive. They are based on state variables, and it makes a formula with them as an input and says, in this case, you should either recommend lumpectomy or mastectomy. And that data goes into the formula, and we track that as well. So we know when a particular data came to our knowledge, and thereby we can document that when we made the recommendation for lumpectomy, which by the way got chosen, we had this amount of data up to that point, and thereby we can state that given that information, we had to make this decision to be conformant to the guidelines, and thereby we prove that we are conformant at any point in time to the guidelines, and everybody will obviously appreciate that we can document that. So finally, I'll just say that this revolutionizes the whole way treatments go on, because it elevates the documentation level a lot, but it also enables people to participate in their treatment and understand it much better. And we think that, by the way, we are going to converge the knowledge of, or the guidelines of many countries to ensure that the whole planet will get treated in an optimal way, and will have a much faster way to convey new knowledge about drugs and treatment procedures to the benefit of everybody. So this is a side of doing this. And we can do it in several languages. As I said, we can switch, given that we've chosen, for instance, the US, if they are still different in the US from the rest of the world, we can convey the US guideline in several languages, allowing people to involve everybody in the family to help them getting cured. So all in all, we look very much forward to making this possible, and we look forward to improving healthcare together with you, making patients much happier and saving you the costs of malpractices or other benefits derived from the fact that you can document your quality. And we look forward to doing that together, starting with breast cancer. Thank you for listening.